Hello, everyone. I would like to invite you to our new CME series on lysosomal storage disorders. This quarterly event is hosted by us, LDRTC, Affinity CE, and CheckRare. This quarterly CME series will provide the much needed information into the new developments in the field of lysosomal storage diseases. And this series will also include leading medical experts throughout the world who will join us and share their new findings and the contributions that made recently to the field of lysosomal storage diseases. We hope that you'll find this series informative and interesting as we welcome to join our discussions with your questions and at the end of each session. The webinars will be available through who are not able to attend through as both live webinars and online. Please check the site of CheckRare to get further information on these events as they occur. So today, I would like to introduce you to rare disorders and lysosomal storage diseases before I pursue with our speaker, who actually needs no introduction, but I'll be introducing him at the end. So basically, we're going to do an overview of lysosomal storage diseases and briefly cover the therapeutic approaches and challenges in lysosomal storage diseases. So what are rare diseases? And we work in the rare disease stratosphere, all of us. Rare disease, by the definition of the FDA, is any disease or condition which affects less than 200,000 persons in the United States. But if we think about rare diseases, individually it's much rare, but collectively they actually pose a public health issue because about 1 in 10 Americans are affected with some sort of rare disease, and almost all, not most of them, have unmet medical needs. So the problems with the rare diseases obviously is the primary lack of recognition, but also there may be lack of presentations such as in lysosomal disorders. So that actually ends up with a lack of diagnosis. And since it is rare, the information in the literature and in the lay public opinion may be biased, and there is limitations of evidence-based medicine in the rare diseases because it is rare. So we actually represent the zebras as rare diseases. If you think about it, rare diseases, think about hoofbeats, zebras, but truly most of my patients think themselves as unicorns, which because they were told that the disease they suffer from, and we end up diagnosis 10 to 15 years later after clinical presentation, is primarily in their head. So LSDs, let's talk about the lysosomal storage diseases as the primarily a group of rare diseases. So lysosomal storage diseases are underdiagnosed. However, if we think collectively about these 50 or more disorders, in reality, about one child or one baby is born with a form of lysosomal storage disease every half an hour worldwide. So despite the opinion that lysosomal storage diseases may present with the most severe manifestations during early neonatal or infantile period, almost all the lysosomal storage diseases have a presentation during infancy, childhood, and later in adulthood. And up until then, the patients may remain asymptomatic or minimally symptomatic. They are multi-systemic disorders, so I usually recommend the students or the physicians that I work with to do an evaluation truly head to toe, even though the organ involvement may be different in each disorder. Why it's important to recognize the lysosomal storage diseases, because there are therapies that had been developed, actual lysosomal storage diseases, open the concept of interventional genetics. And the earlier the diagnosis is made, then the earlier treatment can start and the better chances of preventing further complications of the disease. Actually, this led to the neonatal screening for lysosomal disorders. So we said that the collective prevalence is about 1 in 5,000 live births, and the nomenclature either goes by the protein enzyme that is missing, or the substrate it is collected, or the pathway is involved. So the disease spectrum truly is a spectrum. That this actually slide summarizes the attenuated and also the severe forms of lysosomal disorders, where there is in utero forms of lysosomal storage diseases, such as MPSs 4A and 7. Type 2 Gaucher disease, there is a neonatal and infantile form of neonatal, infantile, and in utero form of diseases. GM1, Niemann-Pick C, Farber, they all have infantile, very early presentation of the condition with hydrops fetalis. So there is a generic or a general genotype-phenotype correlations that also correlates with the enzyme that is deficient and the degree of deficiency. So if you think that this slide, there is obviously a threshold that is where after which you start seeing the manifestations, and that threshold can be at the heterozygous state, or it is much lower or much higher than that. So if we think that about the mild, intermediate, and severe states of the disease in a given lysosomal storage disorder, obviously the severe ones are associated with genotypes with null or very severe missense mutations that causes the altered trafficking. So when we talk about the trafficking, so there are multiple targeting pathways for treatment of lysosomal storage diseases that also takes the therapeutic us to the different therapeutic approaches, such as giving the enzyme that is deficient, and also enhancing the intracellular pathways to actually have a more efficient folding of the enzyme, and also decreasing the substrate. So there are downstream paths in addition to the primary event that occurs and leads to the disease state. So that is the abnormal trafficking, molecular crowding, ER stress, and also the inflammatory and the immune response to the stored substrate that all define the disease state and the phenotype and presentation of each patient. So the therapeutic challenges in lysosomal diseases, obviously this very complex cellular presentation and the pathways, and the phenotypic variability, not even in different disorders, but also within the same disorder, even with the same mutation and the genotype, even within the same family. So we can have families with siblings affected with the same disorder. One may present with one symptom, such as Fabry disease. I have families, one presents with kidney failure, the other sibling presents with strokes, and another sibling has a milder presentation. So the other challenge for any therapeutic approach is the delivery to all systems, that we know that the ERT originally was targeted to the macrophages. However, then we understand that especially brain is very challenging, in addition to joints, bone, lungs, and the other tissues, in addition to liver and other major organs, kidneys, they have a better response. So obviously the inflammatory component has been not so far individually addressed, but we know that all the disorders of lysosomal storage diseases, they are inflammatory diseases. So the therapeutic approaches, as I mentioned, is the enzyme replacement and the small molecules that can potentially cross the blood-brain barrier. And then we have the gene therapy. We will have definitively a separate session for that, which can be given as administered as in vivo or ex vivo. So this slide summarizes, it may be a little bit out of date, since the gene therapy is being moving with leaps and bounds. There is so much advances within the last year or so about the gene therapy protocols, and we have heard them recently with some very promising results. There are both in vivo and ex vivo therapies as depicted in the slide. Gene therapy can be given in vivo, which the genes are transferred into cells while still in the patient, or ex vivo. So basically, you take the immune cells, you knock in the gene, and then you transfer these cells to the patient. They're still patient cells. The vectors used in gene therapy clinical trials, mostly we are talking about now the adeno-associated viruses, but in the past, retroviruses have been used, and lentiviruses, which would be incorporated into the genome. So let me introduce you today's speaker, Dr. Arif Zimran, who obviously needs no introduction. He is the senior physician at Shahare Zedek Hospital, where he runs the Gaucher Clinic. But we know Dr. Zimran, he has been one of the pioneers in interventional genetics, and he's been a part of many trials, including the original Gaucher trials that led to the interventional genetics. So before I give the word to Dr. Zimran, I would like to lastly thank our sponsors, which are Takeda, Chiesi, Ultragenics, Pharmaceuticals, and Spark Therapeutics. Dr. Zimran, thank you very much. Please take the word from me. Thank you.
Thank you very much, Ozlem, for the very kind introduction. Although it would be much nicer to be at a live meeting, I am happy to have this opportunity, and I'm grateful for the invitation. What I will do in the next half an hour or so is summarize current and emerging therapies for lysosomal storage diseases using the lesson learned from Gaucher disease. These are my disclosures. Importantly, if I have any photos of patients, they are all taken with permission. So the learning objectives are delineated in this slide. So why Gaucher disease? And well, it's my expertise, but Gaucher is a very good model for lysosomal diseases. It was the first ever to use enzyme replacement therapy, the first to have substrate reduction therapy, among the first to try gene therapy, among the first to try pharmacological chaperones, and also among the first to use innovative other therapies. Why Gaucher disease? Well, Gaucher is a good model, as we already said, for not just for lysosomal diseases, but also for rare diseases in general. In fact, 2 months ago, I was invited by the Waterfall Foundation from the Emirates to be the first speaker of a series of 6 lectures that were broadcasted to the Emirates as reflection for the new peace relationship between Israel and the Emirates. And I picked the title of my talk as Gaucher as a top model for rare diseases because the very first act of friendship was actually a collaboration of a fashion show of pajamas by 2 top models, one from the Emirates and one from Israel. But we have used Gaucher as a model for rare diseases for several years now, and particularly the first RARD meeting, stand for Recent Advances in Rare Diseases, was using quite the same title of Gaucher disease as a model. So here we go, beside the fact that Gaucher is my main expertise. And we will review the lesson learned mainly from enzyme replacement therapy and from substrate reduction therapy. And we will touch a little bit on pharmacological chaperones and just a hint on emerging therapies. But before we discuss specific therapies, we should not forget the old surgical modalities that were very common before the introduction of enzyme therapy, but still are useful in some cases. Enzyme replacement therapy was first performed at the NIH, and it was the use of a placental-derived enzyme. It was the vision of the late Roscoe Brady, and on the academic side, he actually talked about enzyme replacement therapy already in 1966, a year after his discovery of the deficient enzyme as the etiology of Gaucher disease, and it required also the industrial entrepreneur, and it was the vision of the late Henry Termere, who was willing to invest in the development of a drug for rare diseases, which at that time was quite unusual. But the great success of the first treatment, both on the medical side, but also on the financial side, has opened the door not just to other lysosomal storage disorders, but to the entire field of rare diseases, where Henry Termere proved that it can be profitable to develop drug for patients with rare disorders. Now, the enzyme that was extracted from the human placenta has 3 additional sugars on top of the mannose, and it was understood at that time that in order to be targeted to the macrophage, the enzyme should be mannose terminated. So there were 3 deglycosylation reaction needed to remove the other 3 sugars before making the enzyme mannose terminated, which was actually the secret of the success of this approach compared to failure of previous attempts to develop enzyme replacement therapy. Now, the seminal trial, it was one trial in 12 patients that were treated for 9 months, led to the market authorization of alglucerase, and was published in the New England Journal of Medicine in 1991. I will mention later that it's really important to read this paper because everything that is described in the paper is still relevant for today, and it's not inferior by any way to all treatments we have today 30 years later. And of course, it was also the proof of concept. We see here on the very left that there is a nice reduction in both the liver and the spleen. All the patients responded favorably, but as can be expected in a disease that is characterized by a great phenotypic heterogeneity, that the response to treatment is not going to be uniform either. And we see patient number 7 as a great responder, whereas patient number 3 is not doing as well. There were many debates over the years about the dosage, and in 2009 there was an important publication coming from the Gaucher registry of Genzyme at the time, doing a very sophisticated statistical comparison of 3 groups of patients. The one group on the 60 unit, one on 30, and the low dose of 15 units per kilo every other week. And what they demonstrate is the existence of dose-dependent improvement. However, all those regimens did very nicely, and the debate about the dose, in fact, exists until this very day. The figure on the right side demonstrates the improvement in the bones, which also was realized already in the 1991 paper, where amelioration of bone pain was noted, but at that time they did not have MRI-sensitive methodologies to demonstrate the objective improvement in the bone itself, and later on they used the bone cortical thickness to demonstrate the improvement of the skeleton. But we know today that if you use a very sensitive methodology, like both based on MRI, whether it's the bone marrow burden score or the quantitative chemical shift imaging, you can note that in parallel to the improvement in splenomegaly and blood count, there is also a clear improvement in the bones that can be shown as early as 9 months after beginning of the treatment. And it is all the more impressive when we consider the excellent safety profile of the enzyme replacement therapy. And now it's not just the first enzyme, it's all three enzymes that are available in the market in the US, Canada, Israel, and other countries. And all enzymatic preparation can be given at home. We have used home therapy almost from the beginning because historically we were using a low dose, high frequency regimen where patient receives 3 infusions a week of 2.5 unit per kilo every infusion. It was important for us that the patient will not need to go to the hospital 3 times a week. In the case of children, it also distracts the life of the parents. So we did home therapy as early as the early 90s, but there are some countries like Italy, for example, where home therapy was not allowed until maybe the COVID-19 pandemic, which made home therapy a necessity. Anyway, home therapy is very safe, and female patient can conceive and carry on with the pregnancy while on enzyme replacement therapy. Today, it sounds so obvious. There are some cases where because of pregnancy, the female patients start therapy, but in the early days, reproductive toxicology studies were not performed during the drug development, and there was some warning. So not only that enzyme replacement therapy is allowed during pregnancy in symptomatic patients, it will lead to better outcome. And just a couple of weeks ago, we have a new paper where we compared the outcome of same female patients. The first pregnancies were before they have enzyme, and the later pregnancy while on enzyme replacement therapy, demonstrating an improvement. So we live today in an era where we can choose not just different enzymatic preparations, but also between enzyme therapy and substance reduction therapy. So having choices is, on the one hand, blessing. On the other hand, it might be confusing. And sometimes if you choose wrong, because it's an individualized treatment at the end of the day, it not be ideal. And in a paper that was led by my successor, Shoshi Revel-Vilk, in August 2018, in British Journal of Hematology, we discussed how to manage Gaucher disease in the era of choices. I will show some algorithms from that paper, but it is recommended. So the topic I was asked to discuss today has to do with a lesson learned. So let's review what we have learned. Lesson number 1 is that in order to maximize the benefit, treatment should be started before the development of irreversible complication. Because if you start when already there is an event of osteonecrosis, no matter how much enzyme you will give the patient, there will be a disability. You can fix it with the surgery, but then after 15 to 20 years, there may be a need for revision. You can see on the left side a photo from the Dominican Republic. Even when you start with gigantic splenomegaly, if there is no skeletal complications, you can reduce the size of this gigantic splenomegaly to near normal size and allowing the patient to develop as a normal subject. And in fact, most of the patients today, when they start early, their phenotype is normal, except for the need to receive biweekly infusion or to get substrate reduction therapy when it works fine. Now, avoidance of splenectomy, I already mentioned, is the number 1 most important way to prevent not only skeletal complications, but also, for example, hepatic complications. There is a concern among patients that with Gaucher that they have a greater tendency to develop different malignancies. And one of the names of malignancies that has been brought up in the literature is liver cancer, hepatocellular carcinoma. Well, I think this was true for the era where patients with severe disease underwent splenectomy, and now the preferred storage moved from the spleen to the liver and to the bones. And today we hardly see it, and I allow myself to say that most of the patients who develop hepatocellular carcinoma had been splenectomized before, and uh, with the excessive accumulation of the substrate now in the Kupffer cell and in the liver, they went through all the stages of liver disease, fibrosis, cirrhosis, and hepatocellular carcinoma. There were a few patients, maybe 2 or 3, with iron overload, but nowadays, when we give enzyme therapy early enough, I believe this hepatocellular carcinoma, in contrast, for example, to other hematological malignancies, I think this will disappear. Multiple myeloma is an open question. But needless to emphasize too much longer about the importance of beginning treatment before the development of irreversible complications. Lesson number 2 has to do with the doses. And if I want to say it in a very positive way, I like the citation of Ellen Sidransky from 3 years ago, that good responses have been described with all those regimens, and the issue of the most suitable initial and maintenance dosage remain controversial. The good news is that for the majority of the patient, it really does not matter if you are on a high dose or on a low dose. If you get high dose, it's nice to know that the drug is not toxic and there is no too much concern of having too much enzyme. On the other hand, when you get the low dose, it fits with the philosophy of treating the patient with a minimal effective dose. Ellen Sidransky and Pastores and Morty wrote an editorial to the paper I mentioned already about the dose response comparison that was based on the ICGG, and they discussed some concern, but the bottom line is that even if you look at this, why not get the minimal effective dose? And lesson number 3 is that not every patient need to be treated. Now, this would be probably irrelevant in countries in Asia like Korea or Japan. They don't have the mild common N370S mutations, and almost all the patients suffer from very severe disease. But in the Western world, and particularly among Ashkenazi Jews, and you know, Gaucher is not rare in individuals from this ethnic group. This is, by the way, why we have such a great experience with Gaucher, because 1 out of 17 Jewish Ashkenazi Jews, those that come from Eastern Europe, are carriers of Gaucher, giving a prevalence of about 1 to 800 up to 850. Many patients are homozygous for the mild mutation and will never develop any complications. So you don't need to treat any patient only because they were found probably incidentally to have a Gaucher. And Tama Dinur from our group was the lead author on a paper that was published less than 2 years ago about long-term follow-up of more than 100 patients that were followed for up to 20 years and not without suffering any complication like avascular necrosis. There was a group of patients there who did not want to receive treatment, but when the patient is asymptomatic and is being followed, not all the patients must receive treatment. Lesson number 4 comes back to a comment I already said about pregnancy. I mentioned the safety, but I also mentioned the better outcome in individuals who are at risk for bleeding. And you see here 2 examples from the paper of Yael Cohen and colleagues that I just mentioned. It's one of the new publication on Gaucher disease in PubMed. And we see here 2 examples, one treated with imiglucerase, the other one with velaglucerase, and the performance of the pregnancy with regard to postpartum hemorrhage was much better when the low platelet count was corrected with enzyme therapy. So pregnancy is safe and has a favorable outcome on pregnancies in symptomatic female patients. Now we go to the lessons what is not achieved with enzyme replacement therapy. And the number one unmet need today is to manage patients with neuronopathic Gaucher disease because enzyme replacement therapy does not cross the blood-brain barrier and may fail to improve lung involvement or massive abdominal lymphadenopathy or various Gaucheromas. Now, lack of impact on neuronopathic Gaucher disease is also true for the small molecules of substance reduction therapy that are registered, miglustat and liglustat, but it could be that severe patients who suffer from lung involvement or from Gaucheroma, there are anecdotal hints that they may benefit from small molecules. Interestingly, some of these Gaucheromas or massive abdominal lymphadenopathy leading also to protein-losing enteropathies are typically developed in patients with severe disease, usually type 3B, who receive enzyme replacement therapy. It's a kind of an analogy to the deterioration of the liver after splenectomy, when the enzyme takes care of the kidney disease features, but does not penetrate some other tissues that may become problematic. Fortunately, these complications are quite rare. Lesson number 6, enzyme replacement therapy does not impact on most of the comorbidities, and particularly Parkinson's disease. Lesson, we learn how to manage patients with comorbidity is basically to treat each of the disorder, Gaucher and the comorbidity separately, as our late Yitzhak Rabin, Prime Minister, used to talk about peace and terror, that you must fight terror as if there is no peace process and work to achieve peace as if there is no terror. So Parkinson and Gaucher is a hot topic. And all I can say now, for definitely enzyme replacement therapy does not prevent and does not impact the clinical course of GBA-related Parkinson, at least in the way that we are familiar with. It could be that if we enrich the brain with the enzyme, whether it will be by gene therapy or by other means to open the blood-brain barrier, it might have an effect, but the intravenous therapy, definitely no. A major other limitation of the specific treatments for Gaucher is that they are so costly that they are not available in many of the underdeveloped countries. There are, of course, many patients who benefit from a variety of compassionate and charities, but there are many patients who still even die from severe type 1 Gaucher disease, as you can see on the pictures on the right. Both of them were given to me by Professor Huma Chima from Pakistan, where only the minority of the patients in this country are benefiting from enzyme replacement therapy. Let's talk about substrate reduction therapy. And as a concept, this was a Norman Radin concept that he published in 1973 or 75. We have two small molecules, miglustat, which is a sugar analog, liglustat, which is a ceramide analog, and they both trick the glucocerebroside synthase. And by partial inhibition of the substrate, there will be less accumulation of that glucocerebroside. But as you can see on the left side, the synthesis of the glucocerebroside is the first committed step in the creation of 100 different glycolipids. And I say often that I'm not religious, but if God created mankind with so many glycolipids, maybe it's not a good idea to reduce their content in the body. We don't even know what their roles are in many of those. And this by itself as a modality makes it a second-line therapy, in my personal opinion. But I say it in relation to the fact that liglustat was approved in 2014 as a first-line therapy. And there are two publications, one from Manisha Balawani and colleagues from the US, so-called KOLs, and another publication from Nadia Belmatog with the European experts in Gaucher. Both have publications with guidance how to treat patients with the liglustat, and both papers have identical algorithm. And if you look at this algorithm, you start with an adult patient that needs to receive treatment, and now you see, you go through the different steps. If the patient cannot be compliant, he will go to enzyme therapy. If the CYP2D6 showing that he's ultra rapid metabolizer, he will never achieve a blood level, he should go to enzyme. Then there is a list of concerns like pregnancy, lactation, existing cardiac disease, liver disease, renal disease. When you have all these problems, you are not suitable for liglustat, you go to enzyme therapy. In other words, if you are treated according to this algorithm, enzyme therapy move from first line to second line. Now, what is the story of SRT? I already mentioned that as a concept, it's problematic. But there is a proof of concept for efficacy, and it does impact favorably key disease features, liver, spleen, cytopenia, bones, biomarkers. This is why it gets a market authorization. But if you really go through the literature, there is very limited comparative data, mainly from the ENCORE study. The performance on liglustat is inferior in general to the performance of enzyme replacement therapy in general. Safety concern is relatively more significant with SRT than with ERT, and it is also reflected by relatively high dropout due to adverse events in the official clinical trials or in real life. I already mentioned that the current formulation do not reach the brain and hence are not suitable to treat the neuronopathic features of patients with type 3 Gaucher disease. But many patients prefer obviously to receive tablets than to receive lifelong infusions. And there are some reports showing patient satisfaction and better quality of life with oral therapy. But as I said, when I went through the algorithm, children, pregnant women, patients with other medical problems, those who receive many drugs, etc., they cannot benefit from liglustat. And miglustat has not gained popularity anyway. Well, I did tell you that patients like to receive oral medication, and there is already a paper last year published in American Journal of Hematology showing some of the real-world data from liglustat based again on the ICGG, and what real-life data or real-world data show is that what you saw with the clinical trial is more or less what you see in real life. There is a maintaining stability or correction of the key disease features in naive patients. On the right side, you can see some figures from a paper that is not existed yet. It's in preparation, but this is based on a master thesis that was written by Jolene Esteti from our group, and she looked at 20 patients who switched from enzyme therapy to liglustat in our clinic, and there is a high dropout rate. But if the patient tolerated the drug well, the results are as good as those that were reported by our American or European colleagues, maintaining stability or even slight improvement with the changing of the modality. But coming back to the review of Revel Vilk and colleagues from British Journal of Hematology, our algorithm is different than those published by Balawani and by Belmatov separately. First of all, in type 1 Gaucher disease, we separate between asymptomatic and symptomatic. I already made this comment that many patients can maintain without treatment, but of course, they need to be followed. We are relying a lot about lyso-Gb1 as a sensitive biomarker. When this goes wrong, we treat the patient. If we go to the symptomatic patients, usually we give enzyme replacement therapy, but if the patient is unwilling or unable to receive enzyme, then we give SRT. So the issue of first line, second line is a kind of, it's kind of semantic if we use unwilling. A naive patient can get eliglustat as the first specific therapy, and for him, it will be first line therapy. When I talk about first line, second line therapy, is from the perspective of pure medical considerations. Pharmacological chaperone was a topic of my talk in 2019 in Fairfax, in another series of lectures that is organized by Ozlem and colleagues. And ambroxol is important because it has an effect. So it's a pharmacological chaperone that was identified by the colleagues from Toronto. The realization that Gaucher disease is not just a lipid storage disease, but also a misfolding protein disorder has been known since 2005, more or less, and the misfolding may lead to lack of the mutant enzyme because some of it is degraded through the ERA, the endoplasmic reticulum-associated degradation, as part of the quality control of the cell to get rid of faulty proteins. So if we use the chaperone, we can bypass this early degradation. Some of the misfolded protein never leaves the ER, which lead to this ER stress, inflammation, fatigue, and other manifestations, and possibly also to the relation with Parkinson. So using pharmacological chaperone is a concept that is based on very sound science. Unfortunately, the first chaperone did not receive did not develop beyond the phase 2. This was isofagamin more than 15 years ago, and it was at that time that the search for existing molecules identified a cough medicine, over-the-counter ambroxol, to be suitable to work as a chaperone. And it is effective to some patients with type 1 Gaucher disease, but more importantly, because it crosses the blood-brain barrier, it has demonstrated efficacy in patients with neuronopathic Gaucher disease, and the pioneer here is Professor Ono and Dr. Narita from Japan. They have done much more work than what is being published so far. There is a paper from 2016 about the first 6 patients, I think, or 5 to receive ambroxol. The dosage must be much higher than the one given as a cough medication. And very dramatically, there is an effect on the motor sites of the neuronopathic disorder, specifically the elimination or amelioration of myoclonic epilepsy or other types of seizures, as well as other improvement in ataxia, improvement in the supranuclear gaze palsy, the oculomotor apraxia, improvement in pupillary light reflex, and some of the other tests that are being used. They have not seen a dramatic effect on the cognition, which is worrisome in the context of GBA-related Parkinson. But Anna Narita presented 2 or 3 years ago in Berlin already more than 20 patients. And the same Jolene that I mentioned before is the lead author on a multi-center registry, investigator-initiated registry that we have established in order to expand our database, mainly on the safety of ambroxol, because many doctors, even when they had a 6-year-old child with type 3B and myoclonic epilepsy, are reluctant to prescribe or to recommend a drug that has not been tested in normal clinical trials. But when there are no clinical trials and severe medical problems, you need to do anything you can for the patients, and many times it's the use of the ambroxol. And it's only because ambroxol is a generic drug with many manufacturers, and it's relatively cheap. Anyway, in the paper that we recently published in American Journal of Hematology, we highlight safety information of 41 patients, and in the discussion, we also mentioned the publication from Japan and from the UK. And overall, there have been more than 100 patients whose safety data is published here or there. And I believe if more of us will enter data, maybe this registry will be replaced by the registry that is now just a couple of days ago was launched by the International Gaucher Alliance. If we have much more data, we will be with a better position to use Amroxol. It will not work on all the patients, but some of the patients, it makes miracles. Now, of course, Gaucher is a model. Fabry disease is a sibling disease. There's always an argument which disease is more common, probably Fabry. So in Fabry disease, there is a registered chaperone made by Amicus, migalastat, already with good data. So the lesson that we have learned from pharmacological chaperone, of course, they fulfill the proof of concept, and both with regard to safety and efficacy in Fabry disease and also in Gaucher disease. And it's particularly relevant today to neuronopathic Gaucher disease and GBA-related Parkinson. But it is mutation dependent, and some of the mutations are not amenable to the effect of the chaperone. And drug reimbursement issues are also challenging here, because if you are not using an official drug, there is no way to claim reimbursement. So even though I said it's much cheaper than ERT or SRT, it is still too much for the average patient to pay out of pocket. One slide to talk a little bit about emerging therapies, 1 or 2 slides. So we are now with 3 ongoing clinical trials using gene therapy, either the AAV9-based in vivo, where you direct inject the viral genetically engineered particle with a human enzyme. If you inject it to the vein, it will go primarily to the liver. If you inject it to the CSF through the cisterna magna, as the case of Prevel Therapeutics, it will go directly to the brain. There may be cross pass from the brain to the periphery or from the periphery to the brain. There are challenging clinical trials, but they are now ongoing for type 2 Gaucher disease and for GBA-related Parkinson with regard to Prevail, and to type 1 Gaucher disease when we talk about Freeline from the UK. And then there is the ex vivo modality where you use lentivirus. You take stem cells, then you transfect them with a virus in the lab, but you need to go through conditioning in order to allow the genetically engineered stem cells that now have the glucocerebrosidase perfect gene in order to make it repopulate and dominate. And the conditioning step is the key challenge in recruitment of patients on setting the indication for this ex vivo gene therapy. But if it works fine, it may be a one shot, and you will not need the biweekly infusion, and you will not need to receive daily tablets, so time will tell. Then there are new SRTs that cross the blood-brain barrier. One of them is venglustat. We hope it will be safe and effective for patients with type 3 Gaucher disease. It has failed to move from phase 2 to phase 3 because of inefficacy for GBA-related Parkinson. And then there is arimoclomol, which is like a pharmacological chaperone, but it's actually a stimulant of the Hitchcock protein 70, which is a natural chaperone in our ER. So by making this more effective, you may bypass the concern of other pharmacological chaperones that are mutation dependent. There was a phase 2 clinical trial in India, but it has not been published yet. And it shows some promise also in the case of GBA-related Parkinson. So we don't have any of those now as registered therapy, and neuronopathic Gaucher disease is still number 1 unmet need, but it's nice to know that something may shine in the horizon. And with this, I want to thank you for your attention. You see, I'm surrounded by very talented and brilliant ladies, and I want to thank you for your attention. I hope I didn't go too much over time.
Thank you for Dr. Zimran for this wonderful presentation. So we have actually many questions. I will ask the first question to Dr. Zimran. Is lyso-Gb1 the best biomarker for assessing Gaucher treatment efficacy? And what do you think about the biomarkers?
Well, thank you, Ozlem, and I think so. I think that lyso-Gb1 or glucosyl-sphingosine is today the preferred biomarker. We didn't have time to get to the detail, but the importance of biomarkers are that they reflect the overall burden of the disease. It's kind of tell us how many Gaucher cells exist and what is the impact of their existence with regard to potential complications. So it's not the only biomarker, and there are many of you know about chitotriosidase, which was the first specific biomarker, but then it was found to be elevated in other diseases, CCL18 and others. But what is so nice about lyso-Gb1 is that it is both the most specific biomarker, so it only reflects Gaucher and glucose accumulation, and it cannot be found in other diseases, and also it's very sensitive. We have published recently that reduction in lyso-Gb1 actually preceded the parameters like improved platelet count or reduction in spleen volume, which are the next sensitive key disease features. I also want to say in parentheses to remind you that the advantage of biomarker is that it allows us when we make the diagnosis, it's a kind of a quality control. You find the patient with low enzymatic activity or with mutations, and it has elevation of the lyso-Gb1, it's 100% Gaucher. Then it allows us to follow a patient. If the patient does not need to receive treatment, and there are some, as I've shown you in one of our reports, if you do not treat a patient with mild disease, you want to see that the biomarker does not change. Because if there is going to be some progression in the disease, it will start with the biomarker. Then you need to see the patient more often and possibly offer therapy. And when you treat the patients, you want the biomarker to go down. If there is no change in the biomarker, you need to consider what and why does it happen. And the other good characteristic that make lyso-Gb1 an ideal biomarker is that it's not only the most sensitive and specific, as I already mentioned, but it's also very reproducible. When we, for example, followed chitotriosidase in the course of a patient in a clinical trial, and we wanted to follow every month, for example, each time we measured the chito, we had also to measure the previous one to overcome the problem of variations. In the case of lyso-Gb1, it's highly reproducible, and it does not need this type of repeated measures. And it can be done on a dry blood spot. There are some issues of the cost of the samples which differ in country to country, but we have used it intensively since 2014. Outside the context of clinical trial, it's the only biomarker we rely on. Of course, there will be the serum ferritin and the HDL cholesterols and others, but we found it to be extremely helpful in the management of the patient. And if you remember the algorithm we showed you about following untreated patient, it usually be the lyso-Gb1 that will guide us if we can continue without therapy or we need to put the patient on therapy. I think it's also valuable in the future when the number of patients using lyso is going to increase. It may allow us some option to compare between the different modalities or different enzymes. So the answer is yes. Lyso-Gb1 today is the number one biomarker that we have, and it is very good. It's also, by the way, elevated in the CSF of patients with neuronopathic Gaucher disease, and in the two cases where compassionate gene therapy of Prevail was given to two patients with type 2, It was nice to see the proof of concept that the enzymatic activity in the CSF increased and the lyso-Gb1 level went down. Unfortunately, the patients are too sick at the time that the procedure has been done, and the clinical course continued to deteriorate, but the biomarker itself is very reliable and very helpful. Yes.
So I'm just going to include one, obviously, that is experience with the different biomarkers. So I take lyso-Gb1 is obviously the toxic product of the circulating substrate, and it comes from the major organs, liver and spleen, and it does correlate very well in an untreated patient with the organ sizes. And also, we can probably guesstimate the patient's severity with the level of, the level of the lyso-Gb1. When I see the hundreds or even thousands of values of lyso-Gb1, obviously this is not going to be a type 1, it's a more severe infantile presentation. The other thing is Kaito. Kaito is they represent two different entities. Actually, lyso-Gb1 is this direct derivative of the substrate, whereas the Kaito is the one of the downstream events which shows actually macrophage activation. So it usually obviously correlates with each other because macrophages engulf the substrate that is seeping through or within the tissues, but then they exert a response, and then this leads to the inflammatory aspects of the disease, which you follow the HLH or hemophagocytic lymphocytic hemophagocytosis markers, which are the ferritin, ACE, TRAP, this and that. So basically, they are both, I think, show different pathophysiologies that interplay and gives us the whole clinical spectrum of Gaucher disease. And some patients, we have Kaito is obviously out of proportion, is increased than lyso. And some patients, even though we are able to quiescent the Kaito, we're still seeing this residual Kaito lyso-Gb1 that is accumulating, and we're not able to keep up with the treatments. Actually, one of my patients did a wonderful experiment by herself that obtained blood samples just for randomly LVC, but one was right before the infusion and the other one is right after the infusion, and there was almost a 50 units difference of lyso-Gb1, which indicates the disease actually rolls on itself during these two different time points which are between the treatments, so which actually proves us the disease is progressing even with the treatment for some patients. So they are very useful. That is my 2 cents on that, and we don't have too much time. There are 2 more questions I will ask. So there is one actual last question that I want to ask. This is really, really a burning desire. So let me see what. Since there are for Gaucher disease, and which is going to be true for other disorders as the treatments start coming up. So how do we decide which patient is a candidate for a specific treatment? And if you have many enzyme options, obviously, how do you choose between the enzymes?
I think this is a very complex question because on the one hand, we like to view all the enzymes as almost the same, but they are not the same. They do differ from one to another, but the majority of the patient will respond favorably to all 3 enzymes. There was one report that has demonstrated a kind of equal performance in the first 1 year of treatment. So what we do in Israel, even though the enzymes are not identical and there are several differences, for a newly diagnosed patient, we allow the bureaucrats, we allow the healthcare scheme to choose the less costly enzyme of the time. The price is only presented to the public when the drug is approved, but there are all kinds of behind-the-scene negotiation between the manufacturer or the distributor and the payer. And if one enzyme is substantially less expensive than the other 2, we think that from a social justice point of view, it's okay that any enzyme will be the first to use. However, Of the three enzymes, tallyglucerase alpha is a bit more immunogenic, and we found that the likelihood of severe allergic reaction is much higher if the patient has a medical history of drug allergy, food allergy, or any atopic autoimmune diseases. So for these patients, we ask the payers not to begin with the tallyglucerase alpha, but prefer the other two enzymes. When we don't see good response, and in Israel we begin in a lower dose compared to the US. In the US, usually start with high dose, and when the patient is doing well, some of the centers will reduce the dose. In Israel, we do the other way around. We start with a low dose, and we increase the dose if there is not a satisfactory response. So if a patient does not show a satisfactory response, and if he is getting tallyglucerase or imiglucerase, we usually ask the healthcare scheme either to double the dose or to switch to velaglucerase alpha. Velaglucerase alpha or Vipriv has the amino acid sequence like the wild type enzyme, whereas imiglucerase and tallyglucerase alpha have one amino acid substitution, which we believe is a key cause for some difference when you compare to velaglucerase alpha. Also, if you remember, we talked about the mannose residues. The mannose actually will lead the enzyme to enter the cell, so the penetrance will be better with velaglucerase compared with imiglucerase. For example, if we trust the study that was performed in the Weizmann Research Institute by the group of Tony Futterman, and this has to do with the fact that velaglucerase alpha is 100% mannose terminated, so is tallyglucerase, but there are more mannose residues on the molecule of velaglucerase alpha compared to tallyglucerase alpha. So if the patient does not show a favorable response with the mutant enzyme, we prefer to give the other enzyme. Of course, there may be a patient that will do better on one other than the one enzyme and not necessarily the other one. And velaglucerase alpha is also, maybe because it is made in human cell line, is less immunogenic. And there are many patients, we saw patients coming from the States who arrived to Israel to spend a year in the yeshiva, in this religious kind of a college, university, and they come with their Cerezyme vials plus Benadryl and hydrocortisone as a premedication. We found that if a patient requires premedication and we switch to velaglucerase alpha, in 9 out of 10 patients there will be no need for premedication. So this is also one of the considerations. But to be honest, there are not a lot of high quality prospective double-blind studies that will compare all those enzymes beyond the short period of time that was required. There was one comparative study between alglucerase and imiglucerase, and there was one study comparing velaglucerase to imiglucerase, but they're all short-term in different situations. So maybe some of my colleagues will not agree. We have this impression, as I've outlined before. We also believe that the strategy of starting with a lower dose it goes with a philosophy of treating the patient with a minimal effective dose rather than with a maximal tolerated one. However, in children, we give a higher dose, and if a patient presented in a very severe or acute situation, for example, first diagnosis of a female patient during pregnancy, and she's now 3-4 months into pregnancy with very low platelet counts, we will start with high dose therapy because you will receive a faster improvement and more robust with a high dose at the beginning. Actually, Ozlem, you can answer your questions as well. As far as it relates to substrate reduction therapy, I already mentioned in my talk, it's a measure of, in the majority of the patient, they will start with SRT or switch to SRT because they want to be free of infusions. There are few patients who did not respond well to enzyme therapy and sometimes changing modalities, like those cases with Goker-Alpan lymphadenopathy, lung involvement. Sometimes there may be advantage of penetrating some resistant tissues with small molecules.
Thank you, Ari. So
But
this
maybe you should answer the question.
I actually everybody has different kind of approaches. So I usually start, with a patient with a higher dose and go to lower when I stabilize the patient. Obviously, the patients that I receive may be a little bit more severe than the general homogeneous population. In Israel, we see the most N370S homozygotes, especially children. So I do start with a higher dose, and we
How
let
do you choose the enzyme? How do you
how
choose
do
one of
I
the
choose the enzyme? It is in our case, it's a little bit easier because occasionally the insurance companies dictate what to use unless there is a medical necessity. Then we'll go whatever they choose to do. If the patient has been on a certain kind of enzyme and has been stable, and if the insurance requires us to change, then we will not do it because we think that the patient is stable on that enzyme. So basically, it is not as simple as there are many things that feed into that equation. But obviously, these are all enzymes are hypothetically made one to one, meaning as far as the efficacy is concerned. So that is, and actually, we have a discussion with the patient, and we respect their choices too, meaning we guide the patient. But there are some patients, have some religious beliefs about having animal or, mammalian developed products. So we respect those too. So that is a little bit, that is not a simple answer, one shoe fits all. So this will actually conclude our today's presentation, and I do deeply thank to Ari for this wonderful presentation. And at the end of the presentation, we would like to thank again to our supporters, Takeda Chiesi, Ultragenics Pharmaceuticals, and Sparks Therapeutics. So before I actually have the participants go, we will please claim your CE credit from the website that is listed here.